You're tuning into the O&P Check-in, an SPS podcast. I'm Brendan Erickson, a regional sales manager at SPS. This show brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community. Co-hosting with me today is SPS Sales Account Manager and Certified Prosthetist Orthotist, Pierre Masson. Welcome, Pierre.
Glad to be here. Thanks, Brendan.
Yeah, buddy, let's do it. Let's get started.
Empower your patients with the C-Leg, the most trusted, proven, and preferred MPK. From descending ramps and navigating stairs and uneven terrain, the C-Legs dynamically adapts to everyday situations, empowering your patients to live fully. Now with an IP68 rating and a manual lock function, the most trusted and preferred MPK is more durable and reliable than ever. Discover more at spsco.com.
SPS University has two new courses from TrueLife. Discover the Seattle Scribe prosthetic ankle-foot system and learn all about treating drop foot with the Matrix Carbon Fiber AFO. Each course is worth 1 CEU, and there are many more courses to choose from. Open an SPS University account today by visiting spsco.com/SPS-university. Hello, listeners. Joining us today is Bryan Malas, the director of the Orthotics Prosthetics Department at the Ann and Robert H. Lurie Children's Hospital of Chicago. Bryan is also an associate professor of physical medicine and rehabilitation at Northwestern Feinberg School of Medicine. We're excited to chat with him today about how to increase patient compliance and confidence when it comes to scoliosis bracing. Welcome, Bryan.
Yeah, thanks, Brendan. Thanks, Pierre. It's a pleasure to be here today and really looking forward to our discussion.
Yeah, and it's great that we have Pierre here because I know you two worked together in the past. And Pierre, you want to say hello to a longtime friend?
Hi, Brian. Nice to see you again.
Yeah, likewise, Pierre.
But the funny thing is I'm seeing Brian right now because my son is wearing a scoliosis brace.
Look at that, full circle.
So
yes, indeed.
And Brian's the one that fit it.
Well, cool. Well, thank you so much for joining us, Bryan. We always do this. Could you kick us off by sharing a little bit about yourself and how you became involved in O&P?
Yeah, of course. Always a good starting point, I think. So happily married with 2 adult children. I grew up in Ventura, California. And for the listeners that don't know where that is, Ventura is located 20 miles south of Santa Barbara and 60 miles north of LA. As you would guess, being a beach community, it was a great place to grow up. And I actually got into the profession through my mom, who is a physical therapist. She worked with a local orthotist in my hometown, and he asked if I would be interested in just cleaning up his lab. And this is back in the early 80s. His name's Dave Pinto and really was my first mentor. It was a single-person practice with limited support staff, and because of that, my role quickly expanded from cleaning up to technical work and increasingly being kind of a second set of hands for taking impressions and measurements. And then I often went with him to do hospital calls, so carrying the casting bag and the materials. And it was definitely a different time back then where there was more latitude to do those types of things, where you could go into a hospital and not necessarily have the privileges there, but I certainly learned a lot. When I was 15, he graciously took me to visit his alma mater, which is at the time was UCLA Orthotics Prosthetics program. And after that visit, I was hooked. I knew that this was the profession for me. So really from that point forward, I directed all of my coursework towards kind of that endeavor. I ended up going to Long Beach State, where I was a student athlete and received my degree in anatomy physiology. And my initial plan, obviously growing up out there and getting my first taste of what orthotic prosthetic education looks like, was really, I wanted to attend UCLA's, and it was at that point just a prosthetic certificate program, but they ended up losing their funding, and then the program closed the semester before I graduated. So kind of went with my second option, ended up applying to Northwestern University's orthotic certificate program, got accepted, graduated, went back to California, And I loved Chicago, but I definitely was kind of a beach boy. Had no intention of going back to Chicago. Had completed my 1,900 hours, which is kind of back then the equivalency of the residency that we have in place now, and necessary to sit for the certification exam. And there were some things I had some questions about, and so I sought counsel of the director, my director at the time, and the current director, Jim Russ, back at Northwestern, and sought his advice on some things. And he ended up telling me that there was a position that opened up for a junior instructor position at Northwestern and that I should apply. And really, Brendan, that ended up being kind of the watershed moment in my professional career. At the time, it's interesting, at the time teaching was definitely not in my wheelhouse, but I just had this strong sense and feeling that this was the right path. So I nervously applied with a great deal of trepidation, was offered the position. So in the early 90s, I found myself back in Chicago, taught full-time in Northwestern for 11 years, 8 of which I was the director, which I could never have imagined. And then 20 years ago, I moved into my current role, which is the director of the Department of Orthotics and Prosthetics. And as you mentioned, at Lurie Children's here in Chicago. I was very fortunate that as I transitioned over to Lurie Children's, I was able to retain my faculty appointment. And so I still teach at Northwestern and do other things related to education. It's definitely more than I ever could have imagined, and really provided me with some just amazing opportunities throughout the years of my professional career.
So how many practitioners have you taught over the years that should know you on this podcast?
Wow. So if I was there 11 years, and that was during the certificate program where we would have 2 cohorts a year. Each cohort was 24 students. So if 48 students a year times 11. And then going back part-time and lecturing to those students. And now I've been there, 30 years, which is hard to say. But yeah, tremendous amount. The best part for me, Pierre, when I go to national meetings and to see former students, to see what they've done and how the teaching that was done, how that just continues to carry on. Because they're either taking that and they've applied that in the clinical realm, and in many cases, they're teaching that to someone else. And they've added a different flavor to it. They've added greater experience. So yeah, it just keeps going on, and you're very humbled by that.
Okay, so I expect this to be our biggest podcast ever, and you reach out to all your students to let them know to listen to it. But now, diving into what our topic is, for pediatric patient presenting with idiopathic scoliosis, could you share what their treatment options are?
Sure. Yeah, it's a good question. Really kind of 3 broad categories. There's observation, one category, the second orthotic management, and then finally surgery. But we need to qualify that and unpack it a bit. Observation is typically associated with smaller curve angles, usually under 20 degrees. Observation, I think, might imply that this is passive, like a passive waiting game. And sometimes that's true, but increasingly, we see that patients are receiving physical therapy in the form of the Schroth method. And then the second kind of category would be more for our moderate curves, so 20, 25 to 40, 45 degrees. And that really falls in the window of orthotic management and where we can be fairly successful in impacting natural history of the curve. And increasingly, we're seeing a combination of orthotic management being used with therapy. And the therapy is certainly complementary to what we're doing. We can see that the things like that are being done with the Schroth method, we see that there's increased flexibility of the curve. And what's good about that is that maybe we don't have to apply as of an aggressive force with the orthosis, and it makes tolerating the system that much better for the patient, which is great. And finally, the last kind of treatment option is for the larger curves, so really over 45 degrees. And with that type of degree magnitude, if we're talking about AIS, adolescent idiopathic scoliosis, it just really becomes too difficult to stabilize orthotically. Surgery is required at that point.
So you guys were talking about tolerance and different levels of curvature and everything. And I assume for the patient, especially a pediatric patient, the tolerance of that can be pretty tough. How do you deal with compliance as a challenge for pediatric patients, and how do you overcome that?
I think that is the question, especially with this particular topic with the patient population that we're talking about. It really starts with context. And before really considering the compliance challenge, it's important to really recognize where many of our kids are in terms of their age and development. So compliance is often less of an issue, I would say, with the younger kids. I noticed that, if we put a spinal orthosis on a child who's 8 or 9 years of age, many times they're fine with it. And they get a TLSO, they know that they're going to get another one. We typically put these transfer designs on the brace to improve compliance. That's one way. And these kids will sit there looking at the display cabinet that we have with the different options, and they're picking out the transfer for the first one, and then they're already on to the next one. And for the next TLSO, I'm going to pick this design. That is not as much the case when we talk about the adolescent age group. And the things to think about there is what they're grappling with at that age. Body awareness is such a big piece, self-image, and probably the biggest piece is, as they're trying to find themselves, peer acceptance and belonging. So it's important that we not only recognize that before even starting treatment, that we kind of discreetly and carefully we gauge how much these issues factor into their daily lives. I'll take that a little bit further. So imagine, I try to always kind of bring it back to when I was this age and what were the things that, caused me consternation and stress and worry. And what were the things that we would think now are not that big of a deal. For this population, it is a big deal. So imagine when we were all younger, and remember we get the blemish on our face, and that was the end of the world. And now we got to go to school. We're sitting in class. People can see this blemish. Now add to that equation a person that needs to wear an orthosis. And not something discrete, mind you. We're talking about a spinal orthosis. So that despite the fact that we can make it inconspicuous, the patient has to put it on every day. Try to imagine this. They can feel it. They can touch it. It's always there. It's always kind of front and center. I had one girl say that even though, she put the orthosis on, it was very discreet in terms of how we designed it. So you really couldn't tell once the hoodie, the shirt, the garment was pulled over it. But she made the comment that she could still feel that she's wearing it. And because of that, she felt that everyone else could tell that she was wearing the orthosis. So really, that's the most important piece, because if we can always remember how they're walking in to see us, we can always be mindful of that going into the treatment, and we can remain sensitive and offer solutions and appropriate counseling.
And I know, anytime you deal with adolescents, you also have to deal with the parents.
Yes.
How can clinicians overcome all these objections to wearing the brace between the patient, the parents?
I think it's important to think in terms of context of what is probably the most important piece of what we do when it comes to impacting natural history of the curve, where the curve is by looking at the person's age, the how big the curve is, the fact that the curve is likely to progress, and then would put the orthosis on, and we can alter that natural history. The landmark paper that came out in 2013 out of Iowa showed that more than anything, dosage is the biggest variable. We've kind of rethought how we provide and manage this population, knowing that dosage is the big piece. Design's great, it is, but if the child doesn't wear the orthosis, it's all for naught. So we need to be ready to pull in many strategies to improve the dosage. And I would say this is important too, is that each of these strategies are not going to be equally weighted. They're going to be different for each child. So we've got to tailor it to each one of these kids. So first and foremost, if you can't get past this first piece, the rest of it becomes really difficult. And that is honestly establishing the trust with the patient, trust with the family. And that typically starts by, at least I found, demonstrating an interest in the rest of their life. And we obviously, within reason, but I like to ask, how's school going? Interests outside of school. And, if there's something that's important to them that they tell me, I'll certainly make a note of that. So then in the next visit, I can come back to that initially. I really try to have those conversations first and then get into the treatment piece. And, once you establish that trust, you can go a long way with having these more straightforward conversations, really getting to the heart of how they're feeling about it. And then that kind of leads into, or segues nicely into this next piece, which is certainly when I first started, I did this too quickly, and I could see how it just derailed. It derailed not only that first visit, but, ensuing visits after that. You got to acknowledge how they're feeling. You can't rush past that, because they're going to feel unheard and they're going to feel like you don't understand. And so if that means you've got to take a few more minutes, 5 minutes, 10 minutes, it really is worth listening to them, because it will play dividends really for the rest of the time that you're treating that person and beyond just that initial visit. We look to, and again, this is kind of all over the place. Those are the two, I think, most important ones early on. But if we unpack this a little bit further, peer champions, and what I mean by that is there's times where we will bring in strategically other people who have been successful in wearing a TLSO. And even better yet, maybe those individuals were reticent early on to wear the orthosis and had the concern and all of that. And then they became the champion and are like, hey, it doesn't bother me. I'm fine with it. And, I've embraced it and I'm wearing it all the time. To schedule an appointment with that person who's kind of seasoned wearing the orthosis with the new user who's really nervous, and having the peers talk to one another, that can have so much more of a greater impact because it's a peer. The other thing too is friends. I often will depending on the context, but we'll talk to these patients and I'll say, once we give this to you and you go home, I said, show your friends. And I said, you're going to find out that they will look at it and they'll think, that's great. Let's move on. Let's go do what we usually do. And they're not going to care. And that's important, because that, again, they're looking to their peers to be recognized, to be accepted. And when their friends say, hey, yeah, that's great, let's move on, that speaks volumes. If we do a deeper dive more specifically into like design considerations, we really have tried to push the envelope on thinner plastics. And certainly the tendency for us as orthotists is we want to get as much correction as we can. But if getting as much correction, maybe I can get an additional 5 degrees, but I'm pulling with all my might to tighten the orthosis, and now it's too uncomfortable to wear, and now they stop wearing the orthosis or they decrease their dosage. Well, it's all academic at that point. Another thing that we've done is we've gone away from padding a lot of our designs because it made the orthosis thicker. And again, we're trying to make this as inconspicuous as possible. And so now what we typically do is we'll dispense a torso sock, which is breathable, kind of gives the padding quality to it. And then the person can put the orthosis on. So we maybe will go 1/8 inch or 3 millimeters with our TLSOs. And then the other piece I think that's important for listeners to consider, and this may be a bit controversial because there's some designs that are being used now that are super long, especially up into the axilla. But sometimes I found that long axillary extensions, trochanteric extensions, those can be the deal breakers. And so I think we need to be mindful of that, and we need to come up with different types of designs where we can still impact the curve, we can still impact overall balance, but we can make it where it's going to be easier for the person to accept it and wear the orthosis. One that I have found to be very, very effective, and I know even within our department, we don't all agree on this. I like to leave the TLSO fairly long during an initial fitting. I have some of my colleagues, my clinician, they want it to be pretty close to being, you put it on and we don't have to do anything in terms of trimming it. But what I found is that if you leave it long, you put it on, it's uncomfortable in the axilla, it's uncomfortable to sit, and they tell you that. Now you can go back and you can trim the orthosis, and you establish kind of a benchmark for them. They're like, this is terrible, I can't handle this. And now I go and trim the orthosis, I put it back on, and they say, oh, that's not as bad. Versus I put on the orthosis they've never had before, it's perfectly fitting, and they said, this is awful. Well, I've got nowhere to go at that point. So I'm willing many times to let the appointment be a little bit longer to start with this very long, uncomfortable orthosis. And now we've trimmed it down to a point that's they feel like they can tolerate it. And then the last piece is that they've got to see it. They've got to see that this is not, they're not going to be on display. And so once we've trimmed the orthosis, done all of the design changes, we have them put the orthosis on, pull their shirt on, their hoodie, and have them look in a mirror. And I would tell you more times than not, they're very surprised at how inconspicuous the orthosis is. And they'll look from the front, they'll turn their back towards the mirror, and then they'll turn around and look to see, can they see, the orthosis through the garment. And there's times now, I've been doing this for years, people will come in and like, are you wearing your orthosis? And they'll say, oh yeah, I've got it on. And so, when I hear that, it delights me that we've been able to create a design that's much more streamlined, that even for us who are used to looking at this, that we can't see the orthosis. So that's kind of a long laundry list of different things that we do, but I just found that a lot of those can be super helpful in improving compliance as well.
Yeah, it's incredibly interesting, and I don't know the correct word, but it's almost just like this long-term strategy that you guys have to battle, knowing that you're providing a good functional design, but then the really big issue is proper dosage and acceptance. So it's crazy that you go through all these different steps, and it's awesome that you become so creative with it. Once they leave the appointment with you, do you have a strategy of follow-up to reinforce? Do you have any type of newfangled apps that may be out there that can show you, what they've been doing? Is it just your standard outcomes and measures that you're taking, at each appointment? What's the follow-up to make sure that dosage is as accurate as you can see to find the best outcome?
For years, before we had adherence compliance monitors, it was based on what the family told us. It was based on what the child told us. And usually there was conflicting data that came to us between the parents and the child. And as a lot of studies have shown, and what's supported in the literature, is that people tend to over-report. I had to wear a retainer when I was a little kid. I would go to the dentist and say, are you wearing it this many hours? And I would over-report because I was nervous that I was going to give the wrong answer. Having a compliance monitor, having an adherence monitor is a game changer. We would previously rely upon this self-reporting that would take place. And the problem there is it's so subjective. And so now you're trying to base a counseling session of how to improve dosage based off of inaccurate information. And so now we've really moved from kind of the subjective to the concrete. And I'm going to get to the first part of your question in just a second. But think of it this way. Someone who comes in and they say, hey, I wear it sometimes here, maybe 4 hours here. And it's hard to know where to go with that. Versus now they come in, we take out the adherence monitor, or you take a wand over it, and then you can download the data, you can put it into a printable format. And now, much like your PCP doctor who runs blood work, and then they sit down with you and they just simply review what the data says and then come up with a strategy on what can be done, medications, how we can improve what we're seeing with the results, or keep doing what you're doing. And so now we have this printout, and we can show the family, we can show the child, and then we can talk through it. And we can say, gosh, you know what, it looks like you're doing great here, but these days are a struggle. Share with me. Tell me a little bit about that. Why are these days a challenge? Or they are being great, but they're growing tired of it. There's times where I think we can celebrate and have them come out of the orthosis. If they're doing a good job, maybe Friday night is pizza night, or they're going to do a sleepover. Tell them not to take the orthosis with them. You have more latitude to have those kind of discussions when you have the real-time data in front of you. To your original question, Brendan, that was the first part of what we had, was this adherence monitor, where we only could tell when they would come in. Now there's apps available where the family can look, we can look, and we can see, what they're doing in real time, and that can be very helpful as well. The other thing, there's actually evidence to support that this is a benefit to our patients. A paper came out of Texas Scottish Rite. They found that when they actually pulled up this report, they shared it with the child, they shared it with the family, that dosage actually increased. So that's a great thing. It really is. And again, I said game changer, but can't underscore that enough.
Bryan, that's great to learn about how the compliance monitoring works and the dosage and everything. But how about also how can collaborating care strategies help?
I would say first and foremost, Pierre, it starts with a medical team, and a good medical team that's going to communicate beyond just the patient or the case at hand, knowing each other's philosophies, knowing the script for the family. So, for example, when I see an order from a physician that I've worked with, I have a good sense of what already has been said. And so instead of providing information that's going to be contrary, I can provide information that's going to be complementary in terms of my dialogue. So it's not just really continuity of care, but it's continuity of the message. And then that creates a clear and consistent expectation for the family. And then there's some reassurance with the family. They keep hearing the same message. You look at the research, you talk to families. I look at patient-family satisfaction results frequently here at the hospital. And that is a frustration of families, is when they go from one area to the next and they're just not getting the same message. There's not continuity. And I'm certainly fortunate where I can walk down the hall and I can have those conversations. My colleagues that are in the private sector, really honestly, hats off to them, because they may not have that access. So they have to be even more intentional about maintaining those kind of relationships. But really, it goes a long way. It does. The families it assuages a lot of concerns for them, and they're just going to be more apt to being receptive to the treatment that we're laying out for their child.
The monitoring system, do you put that in all your braces?
We do. We're trying to do that more with, even in some cases, lower limb. I think there's an avenue for sure, and we're going to get away from Scoli for just a minute, but there are things like parapodiums or standing frames that we provide, and we talk about the benefits of being upright. But what we don't know is how often these kids are actually wearing these types of devices. And, if they're wearing it 10 minutes a day, is 10 minutes a day enough to help with some of the benefits that we often talk about? So as these adherence monitors become more and more discreet and they're smaller, and now you have some that you don't even have to take out of the orthosis. You can simply take a wand and wand over it, and it can access the data. It's just going to make it easier and easier for us to be able to use these.
Being that we're in the Midwest, idiopathic scoliosis is typically female, so they wear the baggy sweatshirts right now, which is great. So how about your friends in California, Florida? Is it totally a different conversation down there because they can't wear those baggy sweatshirts because it's too hot?
What's interesting is, I'll start with the Midwest, and then the other piece becomes a little bit harder, and we could probably defer to my colleagues where it is a warm climate all the time. Because for us, when is the climate warm in the Midwest? Usually the summer months. And what I find by and large is I'll ask the patient, I'll say, okay, we're into the summer months. What does your day look like now? And here's what the day looks like. I go to bed late. I wake up late. There's a lot of doses that can be achieved inside the home at that point. Because where is it that the kids the home piece isn't as bad. They learn how to sleep with it. It's, do I have to take this to school? That's probably the first question I get. The doctor said I've got to wear it this many hours. And I just saw a little girl yesterday. And based on the amount of hours they want to wear, or the doctor has prescribed, it's 18 hours. There's no way, you can't get around the fact that she's going to have to wear it to school. But she had her uniform. We made the orthosis thin, as discreet as possible. She put her polo shirt on, and it was hiding the orthosis. Now, if you get into like wearing tank tops and stuff, I think it becomes much more challenging in that case. And there's no other way to make it more discreet. You can only go, as you know, Pierre, you can only make these designs so thin, and then you start to lose integrity of the system. And now the biomechanics kind of fall by the wayside.
Wow, all of this is so interesting and amazing, and my hat's off to you. Pierre, I think you'd say the same thing, but the advancements have come so far in just the physical design of the products, but you adding your own experiences in the 30 plus years and all the people you've taught coming together and collaborating through their brains for acceptance and dosage is probably just as or even superior to the design and functionality. So anyway, we want to say thank you so much for providing all these tips. I'm sure there's a lot of your previous students out there saying thank you. This is awesome. They certainly appreciate you. We always open it up at the end. Do you have anything else that we didn't kind of unpack in our questions that you'd like to add? Maybe some shout outs, hellos, whatever you'd like. Floor is yours.
Oh, yeah. Well, first of all, thanks for this. I think these are just great forums to have these kind of discussions and, just to put them out to the community and have them react in a positive way, in a constructive way. These are the types of dialogue and types of things that will just help us to advance. And, at the end of the day, we're all really striving for the same thing. We want to see that we can provide the best solutions and good outcomes for these kids. And I am constantly learning, talking to other colleagues. And, I travel a fair amount with ISPO and have gone to a number of low-income countries and been asked to teach. And I go there and I feel like I need to sit down and be the student because of the things I've learned that they've been able to do with the limited resources and just the creativity and, honestly being able to bring some of those things back. So it's a great profession. Yes, a shout out to certainly any former students and colleagues and my mentors, over the years have been great. David Pinto is one I mentioned earlier. Jim Russ, who I remember the first day I walked into Northwestern, was completely terrified of this big man and became one of my greatest confidants and cheerleaders and just learned a lot from him. Mike Brensick, there's just a number of people, Dan Blocka in Canada. But yeah, a big thanks. And it's certainly special to be able to have a conversation here with Pierre as well. He was a resident, but we also are friends. And then, as you said, Brendan, at the outset, for it to come full circle and, we're managing his son and managing him successfully, which is probably the best piece.
Well, thank you so much, Bryan. This has been tremendously fun and educational and just really, I would say, thought-provoking for me. So thank you so much.
Yeah, thank you, Bryan.
Yeah, it's been a pleasure. Thank you so much.
To learn more about Bryan's work at Lurie Children's Hospital or Northwestern, follow the link in our show notes.
Thank you for listening to the O&P Check-in, an SPS podcast. We hope you enjoyed the episode, and if you did, be sure to leave a review and subscribe to the show on Spotify, Apple Podcast, or wherever you listen to your podcasts. Have a question or topic suggestion? Email us at spspodcast@spsco.com. See you next time.